Today we are going to review a GI effects report. This report is from a 72-year-old female who has had chronic diarrhea for about a year. She also experiences intermittent abdominal cramping. She had a normal screening colonoscopy about 8 years ago. At the top of the front page, we see three main areas of GI function arranged in the DIG format to represent digestion, inflammation, and the gut microbiome. The color-coded circles at the top of the page correspond with the circles on each pillar listed in the middle of the page. The key shows us that red circles indicate a high need for support, and when prioritizing treatment, these areas should be addressed first. In this case, we see that the maldigestion and dysbiosis pillars are red with scores of 9 and 10, and that is where we would want to focus with this patient. You can see the biomarkers listed under those scores that are part of the algorithm that triggers those scores. In the maldigestion pillar, we see that fecal fats have an up triangle and pancreatic elastase has a down triangle, indicating abnormalities with these markers. In the dysbiosis pillar, we see there is a pathogenic bacteria and yeast, as well as abnormalities in all of the other markers in that category. It's worth mentioning that in the inflammation pillar, calprotectin is borderline elevated. This is an important inflammatory marker that we will discuss later. Underneath the biomarkers section, we see a list of possible therapeutic support options. Clinicians can use this as a general reference to guide treatment. The therapeutic options listed here are static on every report and do not necessarily include every possible treatment option. The next two pages of the report include the Commensal microbiome analysis, which is a summary of findings from the 24 commensal bacteria that we measure on page 5 that you can see pictured to the right of the screen. At the top, we see that this patient's commensal abundance is slightly lower as compared to a healthy cohort. It's not extremely low and may not necessarily warrant an intervention. A lower abundance is often seen after a course of antimicrobials or diets low in prebiotics. The dysbiosis patterns include an inflammation-associated dysbiosis score and methane dysbiosis score, which are derived from proprietary algorithms that take into account the commensal bacteria patterns seen in conjunction with other biomarkers. Each zone has a different meaning clinically, and therefore support options may change. In this case, the IAD score is elevated and the methane dysbiosis score is low. We see that this patient's result is in zone 4. The commentary to the right on the report says for zone 4 that this commensal profile is associated with increased intestinal inflammation, which we know from the front page showing us the borderline elevated calprotectin. It says commensal abundance is lower in this zone and antibiotic use for GI potential pathogens should be used with caution. We also know from the front of the report that the patient does have potential pathogens, so it's important to keep this in mind. The recommendation here for zone 4 says that in addition to standard treatment for intestinal inflammation, modulation of the commensal gut profile is encouraged. We can talk about that more in a later section. The commensal balance graphic shows that this patient's result is falling within the yellow shaded region. This compares the patient's commensal findings to a pattern seen in a healthy cohort. Green would be considered optimal, so we might consider strategies that would optimize the microbiome, such as pre and probiotics. Finally, at the bottom of the page, we see the relative commensal abundance graphic, which tells us more about overall balance. There are 7 major phyla that can be seen when assessing the microbiome, and here we are looking at the relative proportions of each phyla as compared to a healthy cohort. The phyla are quite diverse with regards to the bacteria that make up each phylum, and in some cases may be influenced by certain dietary patterns. At the top of page 4, we have the digestion and absorption markers. Pancreatic elastase 1 is a proteolytic enzyme that serves as a marker of overall pancreatic exocrine function. Most people have a finding of greater than 500. Less than 200 is considered pancreatic insufficiency. The patient's finding is 143, which is in the yellow, which means mild to moderate pancreatic insufficiency. When PE1 is low, it's important to determine the cause, and pancreatic enzyme replacement can be started. The support guide offers more information about the causes of exocrine pancreatic insufficiency seen here. PE1 measurements are not influenced by exogenous enzyme supplementation and only represent endogenous levels. Products of protein breakdown are made by bacterial fermentation of protein. The patient's level is normal at 3.0. When elevated, it may indicate hypochlorhydria, pancreatic insufficiency, bacterial overgrowth, GI irritation, inflammation, or bleeding, or increased protein intake. Next, the fecal fat total was elevated. The fecal fat total includes all 4 fats listed. An elevated total fecal fat can identify if a person is not properly digesting and/or absorbing fats. Because the patient has pancreatic insufficiency, this could be contributing to fat maldigestion. Other causes of elevated fecal fats include hypochlorhydria, bile salt insufficiency, SIBO, parasites, inflammatory bowel disease, or celiac disease. In the middle of page 4, we have the inflammation and immunology section. Calprotectin is a marker for neutrophil-mediated inflammation. It's FDA cleared to distinguish between IBS and IBD. This patient's level is 63, which is in the yellow borderline inflammation zone. A finding above 120 is considered significant and warrants a referral for colonoscopy. For levels that are 50 to 120, we recommend following up with another calprotectin in 4 to 6 weeks. Besides inflammatory bowel disease, other causes of elevated calprotectin include infection, chronic NSAID or PPI use, diverticulitis, and colorectal cancer. Eosinophil protein X is a marker for eosinophil-mediated inflammation and can be elevated in association with parasites or IgE-mediated food allergies. This finding is low, which is considered normal. Fecal secretory IgA is secreted from mucosal surfaces. The patient's level is not elevated. When elevated, it may provide information about an immune response to pathogenic organisms or disordered gut barrier function, which has been associated with the development of food allergies and sensitivities. At the bottom of page 4, we have the gut microbiome metabolite section. Commensal gut bacteria anaerobically ferment resistant starch and dietary fiber, including prebiotics, to produce the beneficial short-chain fatty acids butyrate, acetate, and propionate. The patient's total short-chain fatty acid level is low normal, including their N-butyrate level. Low concentrations suggest either dysbiosis or inadequate substrate for commensal organisms to ferment. While optimal levels have not yet been identified, higher concentrations have been associated with decreased GI disease. N-butyrate is the primary fuel source for colon epithelial cells. There are many ways to support short-chain fatty acids. Probiotics, prebiotics, resistant starches, and fiber can be beneficial for raising levels. Prebiotics can be provided as a supplement, such as inulin, fructooligosaccharides or FOS, arabinogalactan, or from diet. Plant foods rich in fiber include whole grains, seeds such as ground flax or chia, legumes, and vegetables. The percentage breakdown of the 3 short-chain fatty acids is a percentage of the total short-chain fatty acids. These are made by different bacteria, and when there's an underlying bacterial imbalance, these percentages may also be imbalanced. So you want to address the underlying bacterial imbalance. In this case, they look balanced. Next, beta-glucuronidase is an enzyme, as you can tell by the ASE ending. This enzyme is made by anaerobic bacteria. It deconjugates and recirculates substances that were packaged for elimination during the phase 2 glucuronidation process. This patient's finding is normal. Elevated levels are concerning. Low or high levels may be due to an underlying bacterial imbalance. If there are elevated levels, one consideration would be supplementing with calcium D-glucarate, which can directly inhibit the enzyme. Probiotics are also beneficial for restoring bacterial balance. On page 5, there are 24 commensal bacteria assessed by PCR technology. We've already summarized what the data means with the commensal microbiome analysis on pages 2 and 3. Remember that the patient had borderline commensal balance and relative abundance findings. It's not uncommon to see H's and L's or highs and lows on this page, as every patient is going to be unique with regards to their microbial fingerprint. We do have a commensal bacteria chart that you can download from our website that lists each organism and dietary or lifestyle associations when the finding is high or low. A few things to point out on this page are the levels of lactobacillus and bifidobacterium, which are found in probiotic supplements and fermented foods. If we look about halfway down the page under the Firmicutes phylum, we see normal lactobacillus levels. Below that, in the Actinobacteria phylum, we see that the bifidobacterium levels are at the lower end. As mentioned, a probiotic may be helpful here. For any microbiome imbalances, it's important to address all the other findings on the report, as well as consider pre and probiotics and lifestyle or dietary factors that may contribute to imbalances. Here we have the commensal bacteria chart that shows the individual bacteria and associations, and I'm showing Akkermansia here. This patient had low Akkermansia, which is important for gut membrane integrity. The chart shows that higher Akkermansia levels are associated with resveratrol, pomegranate extract, inulin, and even physical activity, and lower levels are associated with a low FODMAP diet. Page 6 of the report lists all the organisms that were grown in culture. We have 3 bacteria at the top, Lactobacillus, E. coli, and Bifidobacterium. We see NG, no growth, for Lactobacillus and E. coli, and 4+ for Bifidobacterium. Bacterial culture complements the PCR assessment to provide a more complete survey of a patient's gut microbiota. It's not uncommon for patients to have a few additional bacteria. If the diamond falls within the green zone, it's considered non-pathogenic. If the diamond is within the yellow zone, the organism is considered a potential pathogen, and we provide sensitivities at the end of the report. These are considered potential pathogens, meaning they may be problematic in some patients and others may be asymptomatic. Red indicates a true pathogen. So for this patient, there was one potentially pathogenic bacteria present. Here's a section on Klebsiella oxytoca from our pathogenic bacteria and yeast chart, which can be found on our website. Klebsiella can be associated with diarrhea. At the bottom, we see that there was a 2+ Candida glabrata yeast in the mycology section, which is a potentially pathogenic level. Here we have the sensitivities for the potential pathogen Klebsiella oxytoca. Klebsiella was sensitive or susceptible to 5 out of 6 prescriptive agents in the S column. Anything in the R column would not work. Under natural agents, if the gray shaded bar shows a degree of inhibition, it's considered a good agent to use. So all 3 natural agents, berberine, oregano, and uva ursi, would be good agents to use against this organism. The bottom of the sensitivities page lists a key describing the categories of susceptibility and resistance. The mycology sensitivity shows pharmaceutical sensitivities at the top of the page to fluconazole and voriconazole based on Genova data, not based on the patient's sample. You can see for Candida glabrata, it's only 27.1% sensitive to fluconazole, but 90.9% sensitive to voriconazole. The results of inhibition to nystatin and natural agents at the bottom of the page are patient-specific. We see that there is a good degree of inhibition with all of these agents, making them good therapeutic candidates, except caprylic acid has lower inhibition as compared to the other agents. On page 7, we have the parasitology section. No ova or parasites were seen under the microscope. On page 8, all 6 PCR parasite tests are negative. In the middle of the page, we see that fecal occult blood was negative. We think about fecal occult blood screening for colorectal cancer, but it can be elevated with inflammatory bowel disease, pathogenic infections, and any other condition that can cause GI bleeding. Consistency and color are reported by the patient at the time of collection, and here the patient forgot to report that. Additionally, on this page, some practitioners may add on zonulin family peptide to assess inflammation and gut barrier function. In this case, it was normal. Genova offers add-ons for pathogenic bacteria if clinically indicated, and those are assessed via FDA-cleared enzyme immunoassay. These add-on bacteria include H. pylori, Campylobacter, Shiga toxin E. coli, and Clostridium difficile. These were not added on to this report because the diarrhea is chronic, it's not profuse, and it's not bloody. Lactoferrin is another add-on marker of neutrophil-mediated inflammation, but was not added on here. We do already have the calprotectin, which is a marker for neutrophil-mediated inflammation, and we did see that was elevated with this patient. Now we can come back to the front page and summarize the recommendations for this patient. The priority would be to address the maldigestion, dysbiosis, and inflammation, since those scores were the highest. In the maldigestion section, digestive enzymes or pancreatic enzymes would be appropriate since the patient is in pancreatic insufficiency with fat maldigestion. In the inflammation section, clinicians may support the gut with turmeric or fish oil for its anti-inflammatory properties. Because the calprotectin is borderline, you would want to retest in 4 to 6 weeks to follow it. One more thing to consider with the inflammation, the patient did have a normal screening colonoscopy 8 years ago, and these are performed every 10 years. So depending on the patient and their history, some clinicians may choose colonoscopy if they have concern and the patient has never had a screening colonoscopy at this age. She's 72. For dysbiosis, pre and probiotics to help build abundance and crowd out potentially pathogenic organisms may be appropriate. Saccharomyces boulardii is sometimes used with yeast overgrowth. The potentially pathogenic bacteria and yeast could be treated, and some clinicians may choose antibiotics, while others may use antimicrobial herbal therapy. With antimicrobials that may disturb the microbiome and create more of a dysbiosis, probiotics and prebiotics may be optimal for restoring balance. There are several resources listed here that you may find useful for learning more about the GI effects. We have our support guide, pathogenic bacteria and yeast chart, commensal bacteria chart, and parasitic organisms chart, recorded educational modules and webinars in our learning library, the lab report podcast, and don't hesitate to schedule a medical education phone consultation with one of our medical education team members. We're here to help you with test interpretation or choosing the right test for your patient. Thank you for visiting today.